TopMed Talk.
Hello, welcome to TopMed Talk. I'm Andy Cumpsty and I'm here at Evidence Based Perioperative Medicine EBPOM World Congress in London. And it's a real pleasure to be back. There's a real buzz around the venue. We're in a new venue this year, the British Library. And it's great to hear everybody and see everybody back here again. And it's really good to have some familiar faces and some new faces here joining us on TopMed Talk to get us started. So I'm going to ask Professor Guy Ludbrook and Dr. Ezra Lehman to introduce themselves.
Guy Ludbrook, I'm from Adelaide in South Australia, so I practice there in anaesthesia and postoperative care, but increasingly focus on health systems and economics and how we make the whole thing work, which is not just us as clinicians at the coalface, but responsible members of a community trying to improve population health.
And Ezra?
Yeah, so I'm a anaesthetics trainee at the Royal Adelaide Hospital and a PhD candidate at Adelaide University and the Centre for Perioperative Health Care and Economics as well under the supervisorship of Professor Ludbrook.
Ezra, I've got to start with you. I think you've slightly undersold yourself there, haven't you? So before going into anaesthesia training residency, you've got a pretty strong mathematical background as well.
Yeah, I guess I almost did maths instead of medicine straight out of school. Partway through my medical degree, decided that I was missing the math side of things a bit much. And so I have decided to take on sort of a part-time studies formally through a university studying maths and statistics and a bit of health economics in there as well. That degree is almost finished, almost got that one off the plate. But yeah, it's been great to get that sort of external to the medical world perspective on what health economics is really about, statistics background as well. And it's been fantastic to integrate that over the last few years with Professor Ludbrook and the ARC sort of studies that we've been doing there.
And that knowledge and expertise really shone through in the excellent talks you both just gave this morning. So again, if we start with you, Ezra, so you were talking to us about the pandemic of aging, essentially.
Yeah, that's right. Recently, the Australian government's published their Intergenerational Report, which projects Australia's sort of economic outlook for the next 40 years or until about 2065. And the healthcare expenditure numbers in that document are fairly alarming. And so we thought that it would be great to dive more into the aging and population demographic changes and how that's resulting in increased expenditure within the healthcare space, particularly looking at the perioperative and surgical patients as part of that and exploring how the changes in the sort of population demographics will change that through the next 40 years.
And you presented a number of quite astounding, but also very beautiful graphs, charts, figures in your talk. What are the headline sort of take-home messages for people that weren't able to join us today?
The government's own modelling expects a 6 times increase in expenditure in patients aged 65 and above and a 9 times increase in expenditure in patients 80 and above over the next 40 years. And so that's fairly alarming. And we combine the data from the Intergenerational Report with Australian Bureau of Statistics data, as well as the American College of Surgeons NESQIP data from Australian hospitals to dive a bit deeper into what's contributing to those costs. We found that the outlook is relatively bleak. The number of complications is expected to increase between 60 and 90%, depending on which sort of outlook you look at. The number of readmissions and sort of mortality episodes that might happen will increase by a significant percentage as well. And overall, that means that we'll be seeing a 50% increase in Australia's healthcare budget just from the perioperative space by 2037. And a doubling in the next sort of 20 years. So those are fairly alarming figures.
I can see Guy nodding here next to me. They're pretty astounding numbers, aren't they, Guy?
It's interesting. When we started the Summit series on the hidden pandemic of complications, it genuinely was hidden, and certainly the quantity was hidden. We just kind of knew it was scary and likely to be bad. We'd not seen figures. So what Ezra has done is really put that front and center. And so at least that highlights and brings into the sunshine that there is a problem. We're not going to get activity usually unless we can identify an issue. This is an issue.
And just to really hone in on exactly what that issue is, I don't think anyone can deny the issue is there given the data that Ezra presented, but that issue is not just one single issue, is it? It's not just the population is aging. Again, Ezra had some really nice figures of pyramids, if you like, becoming cylinders as that folds move further up the diagram. But it's not just the numbers of patients that are increasing, With those numbers of patients, as Edram said, the number of complications is increasing, the number of readmissions is increasing.
Exactly. And we keep operating on older people. If we'd said 20 years ago that we would be operating routinely on 70, 80, 90-year-olds, we probably mightn't have believed that. We regularly operate on 70, 80, 90-year-olds, even people above 100. So we keep doing that, and we know that when we do that, there will be more costs associated with that. Some of those are possibly preventable. So we understand complications. We can quantify from Ethanol's work what that is going to cost. And from a whole lot of more recent work, we can start to address that. So there's some macroeconomic issues that we can't deal with, and there's some balance of care issues and what we provide. But on the ground in our world, I think we can deal with, if someone's at risk of complications, can we identify that and can we do something about that?
So I'm going to come back to that in just a second, but just to come back to Ezra briefly, and you highlighted at the beginning of your presentation, although you were presenting Australian data, this isn't an Australian problem, is it?
No, that's right. We think the pattern of aging populations, lower fertility rates, and less migration is broadly spread across Australia, the UK, the US, and many other more economically developed countries. And so while, yes, we did present Australia as sort of a case study, it would be, one would have to think from any healthcare perspective that this is going to be a problem that's going to be facing them at some time in the very near future. And so we can all work together to try to work out what solutions might be applicable for the healthcare systems.
And again, it's definitely a problem that I recognise in the United Kingdom NHS practice. It's in our mainstream news almost every day, that the challenges our National Health Service are facing. And this is one of the problems which keeps being highlighted. Absolutely right. It's not an isolated problem for one country. So what do we do about it?
It's sort of an isolated. So if you look at the OEC data and the old age dependency ratio, which says if you're more than 65, you are old and dependent, which worries me because clearly I am therefore a parasite on society, which I would hope I'm not. But anyway, we'll talk about statistical averages, so that's fine. So it is a genuine global problem, and fertility rates are decimated across the world. What do we do about it? Well, there's a lot. That's what perioperative medicine is about, isn't it? I'd love to believe we could make people magically better in the operating room. There are things we can do, for sure. But what we've leaned to more and more is risk prediction. Who do we really need to focus on? And then what can we actually do about that? And that's when we got into this postoperative high acuity care models that we've, I think, talked about on this program before. We are continuing to see success in that and growth in that, which is kind of fun.
So I know we've talked about that before, Guy, but just for people that maybe listen to us for the first time or maybe not listened to us recently, can you summarize what you mean by that model and specifically what you're doing about that in Adelaide?
So in a nutshell, we realized that our patients in recovery were struggling. When we looked at it, they struggled on the ward and they did worse. So we, in effect, took our recovery rooms, or PACU, depending on where you come from, made that longer, or care was longer in duration till the morning, and the care was more sophisticated. So we call that advanced recovery room care. Advanced implying that it was not just more of, but better, if you like. And that was anesthesia-led and has shown results that really surprised me. We find that the number of complications in hospital is halved if you spend a few hours with me and my colleagues rather than go to the ward. We find that your hospital utilization is dramatically reduced. So days at home as a composite measure goes up by an average of about 4.3, a little higher than that actually on more recent data. A lot of those composed of data that means something to my hospital funders, days in hospital, readmissions, representations to the ED. And more recently, we've discovered that there's a mortality signal. So roughly at the end of the day, out to about a year and a half, your mortality rate is about 35% less if you spend a few hours with me rather than being on the ward. So if we look at economic grids, if you like, that does fall under genuinely better and genuinely cheaper, whichever way you want to look at value.
And again, that comes very nicely back to what you were presenting about the value of healthcare. Do you want to just summarize what you're meaning by that?
Yeah, so if we look at cost consequence analysis, which encompasses cost effectiveness, a whole lot of other things, at the end of the day, we do something that makes the change. That's an outcome. There is a cost associated with that. And it's that ratio that we have to critically look at to see what's affordable. New medicines cost more. Very often that price is worth it in terms of what we achieve. There are some extremely expensive procedures, for example, which may not do a lot and cost a lot, and we as a society have to work that out. And then often system change, redefining and reimagining workflows, and ARC is one of those, you get the sort of big win, better and cheaper, and that's where we sit.
So Ezra, from a resident point of view or trainee point of view, how does the ARC work? If you see a patient in theatre, you operate them on with a boss, with a consultant, and then what happens afterwards? What's the process?
Yeah, so I guess the ARC model begins even before the patient ends up in theatre. With the ARC residents, which I was fortunate enough to be one a couple of years ago, spend their mornings sort of looking through the upcoming patient lists, even for the following days, and identifying patients who are sort of what we call at medium risk of postoperative badness.
What do you mean by medium risk?
So we use a Nesquik risk calculator to identify these patients formally, and at the moment, a 0.5 to 8% risk of postoperative morbidity or mortality within 30 days of surgery is the definition that we use for medium risk. But overall, essentially, these are patients who are not sick enough to need an ICU bed postoperatively necessarily, but they're the patients who we've shown have worse outcomes if they're sent immediately to the ward after having their surgery. Once those patients are identified, we communicate with the anaesthetist and the anaesthetic team and the surgeons on the day of surgery, explaining our plan for these patients and letting them know that they'll be coming to the ARC if everyone's happy with that. And across the board, the surgeons are very, very pleased to know that their patient will be looked after in ARC afterwards.
And for how long for?
Well, at the end of the surgery, the anaesthetist will give us the ARC resident a call. We'll come and meet the patient as they're wheeled out into the postoperative recovery unit, receive a handover from an intraoperative team, and from there, our care begins until the following morning when the patient is ready to return to a ward bed, essentially.
So guys, if it's a short period of intense monitoring inputs that is senior overseen, but it's not senior driven, is it? You've got residents doing that care rather than a consultant attending there all night. And how will the model work?
So we have an attending all day exclusively for that and a residence.
Yeah.
And the workload balance will depend on the day. So there is very senior oversight. At night, the residents keep the things going, but it's active to the point of almost aggressive care. We want these patients well and ward ready by the morning. So we meet them in recovery and put a lot of assessment and active management in place to really get things sorted. It's checklist based, so we go through each system, work out what it is, appropriate treatment algorithms and assessment algorithms. So it's a very busy time. And that's the whole point. And there's a lot to do. I have to say there's a lot to do. When we look at what it is we do, I'm often asked that, and we've published some of this, what are the problems? Blood pressure and fluid 1, blood pressure and fluid 2, blood pressure and fluid 3, pain, respiratory, renal. We've seen an international trend towards less fluid and more vasopressors in the operating room. Whichever data you want to look at, that's what happens. It's not necessarily the best treatment. You can make the numbers look good, but it's not necessarily optimizing perfusion for patients. So that's probably the biggest problem that we receive is patients who have their blood pressure maintained with vasopressors. We receive them and try and move them as rapidly as possible to a non-vasopressor dependent state of euvolemia. And I suspect that underpins a great deal of the outcome. We've got some AI data looking at the associations with outcome. An interesting one of those is if you have been on a high dose of vasopressor in the operating room, you will get a great advantage from coming to us to a limit. If you're on too much, there's probably nothing we can do.
So, and again, we're going to have to close this soon because I can hear everybody start to move back into the lecture theatre, but provocative statement, but given everything we've talked about, you described this model as a big win earlier, talking about better care and better value care. We've talked about this big costly problem of more older people having more surgery. Could that be part of the solution? Is that how we get through it?
It certainly has to be part of the solution. It does have a big impact. On the other hand, there's going to be lots of other things we have impact through. We heard this morning about preoperative assessment, rehabilitation, and patient-focused goals of care. Let's not do surgery if it's not the best thing to do. So I think we can have influence as anesthesiologists pre, intra, and post-operatively. This had a big impact, but we should not just sit and think that that's going to be enough to address this huge problem that Esrom has shown us.
Brilliant. Great summary point to finish on. Thank you both for your time. Let's get back into the session. And always, thank you for joining us on Top Med Talk.
Great to be here.
Thank you very much.
You can find us online on our website, on social media. We're now on X or Twitter as it used to be, now on Blue Sky. We've gone modern. On LinkedIn, YouTube. If you're on any of those things, do hit subscribe, give us a like. It really makes a difference. Give us your comments, give us feedback. And finally, of course, we couldn't do this without the help of our fantastic sponsors, who this year are BD and GE. And they really do keep Top Med Talk open access and free around the world.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.